You know that feeling when your energy just tanks and even getting through the basics feels like a marathon?
Yeah, definitely.
We often just chalk it up to a busy week, but sometimes the answer lies in something you can't even see: your red blood cells. Today, we're diving deep into macrocytic anemia.
And this is a particularly focused dive for you as you gear up for your MSRA revision. Think of this as your direct route to understanding what really matters about this condition. Saves you time, saves you mental energy.
Exactly. We've put together a really comprehensive set of revision notes, hitting all the crucial bits of macrocytic anemia.
Mhm.
We're going to cover, what it is, what triggers it, who's vulnerable, how it affects the body.
What else it might be mistaken for?
Yeah, who gets it, how it shows up, diagnosis, treatment.
The whole picture. Prognosis, potential problems too.
Right. The goal is to give you a solid, easy to remember, and hopefully even, engaging grasp of macrocytic anemia for your revision.
So let's get straight to it. What exactly is macrocytic anemia? How do we define it?
Okay, so at its heart is macrocytosis. That's just the term for having red blood cells that are, well, larger than normal.
Bigger cells, got it.
Now, when those big cells are coupled with a lower than normal level of hemoglobin,
Right.
the stuff in red blood cells that carries oxygen,
The oxygen carrier protein.
that's macrocytic anemia. So you've got big cells, but not enough oxygen carriers overall.
And just to be specific, anemia generally means hemoglobin that's significantly below the average for your age and sex.
Hmm.
Typically below 13 grams per deciliter for men,
Yeah.
below 12 for women.
Right.
But the core issue here is that the bone marrow isn't producing enough healthy red blood cells to carry that oxygen effectively.
Exactly. And the underlying problem is often an issue with how these blood cells are being, well, manufactured in the bone marrow, leading to their larger size.
Mm-hmm.
It's different from microcytosis, just to contrast,
Yeah, good point.
where the red blood cells are smaller. That's often because there's a problem making enough hemoglobin itself, like in iron deficiency or thalassemia.
So macrocytosis is about the cell size, microcytosis often about the content, the hemoglobin.
Pretty much. In macrocytic anemia, the main focus is that increased volume of the red blood cells.
Okay.
So, memory tip. Macro sounds big, means big cells. Anemia means low hemoglobin. Put them together. Macrocytic anemia, big cells, not enough oxygen getting around.
Simple enough.
Yeah.
Okay, now we know what it is. Let's explore the why. What causes it? There are several things, and grouping them might help you remember for the exam.
Good plan. So, the main players, you've got vitamin B12 deficiency.
Right.
And this can happen because of pernicious anemia, where the body's immune system attacks cells in the stomach needed for B12 absorption.
That intrinsic factor issue.
Exactly, intrinsic factor. Or just problems absorbing B12 for other reasons. Then there's folate deficiency.
Another big one.
Yeah, be dietary, not getting enough, or again, problems with absorption.
Okay, so B12 and folate deficiencies are key. What else?
Well, certain medications can do it, like methotrexate, also alcoholism, liver disease, some bone marrow disorders called myelodysplastic syndromes,
MDS.
and even some inherited conditions.
Okay, and it's helpful to sort of subdivide these causes further based on whether they lead to what we call megaloblastic changes in the bone marrow.
Ah, right. Megaloblastic anemia. That's a subtype, isn't it?
It is. It's a type of macrocytic anemia, but with specific features you see under the microscope in the bone marrow cells.
So what makes a cause megaloblastic? What's the difference?
The primary drivers, the classic ones for megaloblastic changes, are vitamin B12 and folate deficiencies,
Okay.
because these deficiencies really mess with DNA synthesis in those rapidly dividing bone marrow cells. But other things can sometimes show these features too, like liver disease, hypothyroidism.
Underactive thyroid.
Yeah. Pregnancy, a high reticulocyte count.
Those young red blood cells.
Exactly, when the body's trying to compensate. Myelodysplasia again, and certain cytotoxic drugs like chemo drugs.
So B12 and folate are the main megaloblastic culprits because they mess with the DNA blueprint. What about the macrocytic anemias without those megaloblastic changes? Normoblastic ones.
Right, normoblastic macrocytosis, so large cells, but no megaloblastic features in the marrow. Alcohol is a big factor here.
Okay.
Also liver disease, severe hypothyroidism. Again, a high reticulocyte count can push the average size up. Other blood disorders like aplastic anemia.
Or the marrow just doesn't make enough cells.
Exactly. Or red cell aplasia, just affecting red cells, MDS again, and myeloid leukemia. And finally, some drugs that affect DNA synthesis differently, like azathioprine.
Azathioprine, the immunosuppressant. Got it.
Mm-hmm.
So just to really nail down those primary megaloblastic causes, it really boils down to vitamin B12 and folate deficiency.
That's the core.
And for B12, it could be that autoimmune thing, pernicious anemia,
Right.
or maybe after surgery on the stomach or gut.
Affecting absorption site.
Yeah, or bacterial overgrowth using up the B12, or just not eating enough B12, like in strict vegans maybe.
If they don't supplement, yes.
And for folate, similar story.
Pretty much. Not enough in the diet, problems absorbing it, maybe increased demands like in pregnancy, losing too much, or drugs interfering with it.
Okay, and the non-megaloblastic ones, quick recap, alcohol.
Which can also cause folate deficiency, remember.
Ah, double whammy. Okay. Liver disease, severe hypothyroidism, high reticulocytes, other blood disorders, and drugs like azathioprine.
That covers the main non-megaloblastic causes, yeah.
Right, that's quite a list for the MSRA. Any tips for remembering these?
Okay, here's a quick memory aid. For the main megaloblastic causes, think BF, B12, and folate, the BF twins.
VF. Or
For
F.
the non-megaloblastic causes, maybe try LAHRA, L for liver, A for alcohol, S for severe hypothyroidism, H for high reticulocytes, and RA for the rest, other blood disorders and azathioprine.
LAHRA, BF, and LSRA.
Got it. Okay, so we know the causes. Who's more likely to get this? What are the risk factors?
Well, they follow logically from the causes, don't they? So anyone not getting enough B12 or folate in their diet, like strict vegans or maybe older adults with poor diets?
Exactly. Then people with GI disorders that affect absorption, think celiac disease, Crohn's, especially Crohn's affecting the terminal ileum for B12.
Or after gastric surgery.
Right. Chronic alcohol abuse is a big risk factor. Long-term use of certain meds like methotrexate, phenytoin.
By anti-epileptic.
And finally, having those specific autoimmune conditions like pernicious anemia itself or maybe certain genetic factors.
Makes sense. If you can't get the vitamins in or can't absorb them or something else is interfering, your risk goes up. Okay, quick practice question for you listening. Patient with known Crohn's disease presents with new fatigue. What hematological abnormality might you suspect?
Good one. The likely answer there is macrocytic anemia, probably from B12 malabsorption if their Crohn's involves that terminal ileum.
Nice clinical link. Okay, causes, risks. Let's get into how it happens, the pathophysiology.
So the basic mechanism, the core problem, is impaired DNA synthesis. This happens in the precursor cells in the bone marrow, the ones that are supposed to mature into red blood cells.
Right.
And this disruption, usually because of a lack of B12 or folate, which are crucial for making DNA,
Okay.
it leads to a delay in the maturation of the nucleus of these cells. But the cytoplasm, the main body of the cells, it keeps growing okay.
So you get a mismatch. Delayed nucleus maturing cytoplasm.
Exactly. That's called nuclear-cytoplasmic asynchrony. And the result is these larger than normal red blood cells get released. And if you have that plus low overall hemoglobin, that's your macrocytic anemia.
So the cells get bigger because the machinery for dividing properly is slowed down. Now, we touched on this, but quick reminder. Difference between just macrocytosis and macrocytic anemia.
Sure. Macrocytosis just means a high MCV, mean corpuscular volume on the blood test. It's just a measure of the average red cell size.
So you can have big cells but not be anemic.
You can, yes.
Mm-hmm.
You might have a high MCV but normal hemoglobin. Macrocytosis is the finding. Macrocytic anemia is the condition where you have both big cells and low hemoglobin.
Got it. And you mentioned spurious or false high MCV. What causes that?
Ah, yeah. This is where the machine reports a high MCV, but the cells aren't actually that big in the body. It could be an artifact.
Like a lab issue?
Sort of. Could be the sample storage. If it sits too long, cells can swell. Or cold agglutinins.
Antibodies clumping cells in the cold?
Right. They can fool the counter. Or very high levels of paraproteins, like in myeloma, or really high blood sugar, or even a super high white cell count. These can all interfere with the measurement.
So technical glitches, not true big cells.
Exactly. Important to rule those out.
Okay. And back to the cells themselves, that megaloblastic versus non-megaloblastic difference again at the microscopic level.
So megaloblastic, the hallmark is that nuclear-cytoplasmic asynchrony we talked about. Delayed nucleus maturation, because DNA synthesis is off, usually due to B12 or folate lack.
The factory blueprint is delayed.
Yeah, good analogy.
Yeah.
But the workers, the cytoplasm, keep building, making a bigger, not quite right product.
Okay. And non-megaloblastic.
Still big cells, but for different reasons. Like in liver disease or obstructive jaundice, you can get extra cholesterol and lipids deposited onto the red cell membrane.
Making them physically bigger on the outside.
That increases the surface area, yeah. So the end result is big cells, but the way they got big is different from the megaloblastic pathway.
That makes sense. Okay, so if you see macrocytic anemia, what else should be on your mind? The differential diagnosis for the MSRA.
Crucial point. Macrocytic anemia is a clue, not always the final answer. You need to think. Could it be another type of anemia presenting unusually? Maybe iron deficiency, though that's usually microcytic.
Or hemolytic anemia, cells getting destroyed.
Yes. Definitely consider bone marrow disorders, especially myelodysplastic syndromes. We've mentioned liver disease and hypothyroidism multiple times, keeps them high on the list.
Right.
Chronic kidney disease sometimes. And always think about medications.
So the takeaway is, finding macrocytic anemia is just step one. You have to dig for the root cause.
Absolutely. It's an initial finding that needs explanation.
Okay, memory tip for you revising. See macrocytic anemia. Don't just leap to B12 or folate. Think broader other organs, drugs, underlying conditions.
Spot on. Now let's talk epidemiology. Who actually gets this? What does it look like in the UK?
Right. UK data. B12 deficiency is quite common in older adults, actually. Around 6% of people over 60.
Yeah, that's significant.
Yeah. Folate deficiency is less common overall, maybe 1–2% of the population.
Okay.
But interestingly, if you look at all causes of just macrocytosis, not necessarily anemia.
Just the big cells finding.
Yeah. Medications are the most common cause, around 37%. Alcoholism next, about 26%.
Right.
Then B12 or folate deficiency, they each count for about 6%. Same for bone marrow dysplasia and non-alcoholic liver disease, also around 6% each.
So meds and alcohol are really major contributors to just having large cells.
Seems so.
And thinking about megaloblastic anemia specifically, there's that strong link with pernicious anemia.
Autoimmune B12 one.
Yeah, typically diagnosed around age 60, more common in women, and often turns up alongside other autoimmune things like diabetes or thyroid problems.
So you need to check for those too.
Definitely worth screening. And remember, overall, B12 or folate deficiency cause the vast majority of actual megaloblastic anemia cases.
Right. And B12 deficiency itself can be linked to Crohn's affecting the terminal ileum, as we said.
Or other rarer causes, yeah.
Yeah.
And there are important health links too, right?
Right.
Associated diseases.
Yes. With pernicious anemia, watch for those other autoimmune conditions. With B12 deficiency, generally, you worry about the neurological problems.
We'll get to.
Yeah. And also a slightly higher risk of gastric cancer, maybe 3 to 4 times higher.
Worth knowing.
And it's linked to high homocysteine levels. Folate deficiency in early pregnancy, big link to neural tube defects.
Crucial public health message there.
And some inherited B12 metabolism issues can also cause high homocysteine.
Okay, so that aha moment for you listening might be just how common B12 deficiency is in older adults. Really keep that in mind.
Absolutely. Crucial for assessing fatigue or cognitive changes in that age group.
Definitely. Okay, so how does it actually look? What are the clinical features? What signs and symptoms might make you suspect macrocytic anemia?
Well, it can be quite varied and often creeps up slowly, especially the deficiency ones.
Insidious onset.
Yeah. Common things are fatigue, just general weakness, looking pale, pallor, shortness of breath, maybe dizziness.
Okay, standard anemia symptoms. Anything more specific?
Glossitis can be a clue that's a sore, inflamed tongue. And specifically in B12 deficiency, you often get neurological symptoms.
The tingles.
Yeah, paresthesia, tingling, numbness, often hands and feet, and maybe problems with balance or walking.
Right. And remember, sometimes just the macrocytosis, the high NCV, is picked up incidentally on a blood test for something else with no symptoms at all.
True. But when the anemia does cause symptoms, it's often that fatigue, shortness of breath on exertion, maybe palpitations.
Heart racing.
Yeah, and looking pale.
And on examination, what might you find?
Depends on how severe it is. You might see pallor check nail beds, inside the mouth, the tongue, maybe a bounding pulse. In severe cases, you could hear a heart murmur, a systolic flow murmur.
Due to the increased blood flow trying to compensate.
Exactly. And pernicious anemia, because it comes on so slowly, can be missed for a while.
Mm-hmm.
So, quick memory aid. Think fatigue and pale for general anemia symptoms, then add tongue and tingles for B12 deficiency, specifically glossitis and the neurological stuff.
Fatigue, pale, tongue, tingles. Useful. Okay, so we suspect it. What tests do we order? What are the key investigations?
First stop, Full blood count, FBC. That gives you the MCV, high MCV, macrocytosis.
The defining feature.
Then you need serum vitamin B12 and folate levels. Check for deficiencies.
Makes sense.
A peripheral blood smear is also really useful. Look at the cells under the microscope, might see those megaloblastic changes if it's B12 or folate.
Okay, FBC, B12, folate, blood film. What else might you need?
Depends on those results in the clinical picture. You might need intrinsic factor antibodies if you suspect pernicious anemia.
Highly specific tests for that.
Yeah. Measuring homocysteine and methylmalonic acid can also help differentiate. Both might be high in B12 deficiency, but usually only homocysteine is high in folate deficiency.
Useful differentiator. What about reticulocyte count?
Good to check. Shows how the bone marrow is responding. Red cell folate is sometimes better than serum folate for long-term status. And liver function tests, LFTs, if you're thinking alcohol or liver disease.
Makes sense. Any other routine tests?
Maybe urinalysis, UNEs, creatinine checking kidney function, looking for clues like in homocystinuria maybe.
Okay.
Coombs test if you suspect hemolysis.
Mm.
Bone marrow exam, usually not needed unless you really suspect a malignancy or are stuck for a diagnosis.
So reserve the bone marrow biopsy.
Generally, yeah. Other tests depend on clinical suspicion.
Stepwise approach then. Basics first, then targeted tests based on clues.
Okay.
Let's talk management. How do we treat macrocytic anemia?
Key thing, treat the underlying cause, always. If it's B12 deficiency, treatment is usually lifelong B12 supplementation. Often intramuscular injections, especially if there's an absorption problem.
By injections to bypass the gut.
Exactly. You start with frequent loading doses to build up stores, then maintenance injections, usually every 3 months for life.
Okay. What about oral B12? Or sprays?
They're around, being researched, but IM injection is still the standard in the UK, especially for pernicious anemia or malabsorption.
Got it.
And it's worth noting, serum B12 level doesn't always perfectly reflect what's going on in the cells. You can have functional B12 deficiency, especially in the elderly, with neurosymptoms despite normal levels.
Tricky. Okay, what about folate deficiency?
Usually straightforward. Oral folic acid tablets, typically 5 milligrams daily for about 4 months, maybe maintenance after that depending on the cause.
Simple enough. Now, what if someone has both B12 and folate deficiency?
Crucial point here. You must treat the B12 deficiency first.
Why that?
Because giving folate alone when B12 is also low can kind of mask the B12 deficiency hematologically, but it doesn't fix the neurological problems and might even make them worse.
Okay, that's a huge safety point. Treat B12 first if both are low.
Absolutely. And obviously, you need to manage the underlying reason. Pernicious anemia needs the lifelong B12. Monitoring maybe checks for gastric cancer risk. Alcoholism needs a whole different comprehensive approach.
Right. And when do you need to get specialists involved? Referral guidelines.
Okay, urgent referral to hematology if there are neurological symptoms or if the patient is pregnant or if you suspect a blood cancer like leukemia or MDS.
Makes sense. Urgent situations.
Routine hematology referral if the cause isn't clear after initial tests or you suspect some other blood disorder.
Okay. What about gastro?
Urgent referral to gastroenterology if you suspect gastric cancer or celiac disease causing malabsorption. Routine gastro referral for other suspected malabsorption causes if it's not pernicious anemia.
All right.
And consider referring to a dietitian if it seems like poor diet is the main issue.
Good practical advice. So what's the overall outlook? Prognosis?
Generally good, actually. It really depends on the cause and how quickly you treat it.
So timely management is key.
Definitely. Most cases resolve well with the right treatment, but untreated or chronic cases, especially B12 deficiency, can lead to lasting problems.
Which brings us to complications. What are the potential downsides if it's not managed well?
Well, severe anemia puts extra strain on the heart, potentially leading to cardiac issues.
Okay.
It might impair immune function, making infections more likely. In pregnancy, folate deficiency causes neural tube defects, devastating complication.
Absolutely.
And probably the most feared complication of long-term B12 deficiency is that irreversible neurological damage, balance, memory, sensation problems.
Wow. So early diagnosis and treatment are vital to prevent all that.
Exactly. Regular monitoring and timely treatment can prevent most of these.
So the bottom line, diverse causes, but needs thorough investigation and proper management to avoid potentially serious long-term issues.
That's it in a nutshell. All right, let's wrap this up for everyone revising for the MSRA. Key takeaways. Macrocytic anemia means big red blood cells, low hemoglobin.
Hmm.
B12 and folate are often the main culprits, especially for the megaloblastic type. But remember those other causes, LAHRA,
BF and LAHRA.
early diagnosis, finding the underlying cause, and treating it properly are absolutely crucial to avoid complications like heart problems or neurological damage.
And as you carry on with your revision, definitely test yourself and check out more resources over at passthemsra.com.
That's right. And don't forget, freemsra.com, brilliant free resource to help you prepare.
Absolutely. And just remember, really understand the nuances of conditions like macrocytic anemia, the causes, the features, the management. That's key to being a confident and safe practitioner. Keep exploring, keep learning.
Well said. Best of luck with the revision.